My name is Vicki Fishneck. I am Clinical Affairs for Osnovatus Systems. And first of all, I want to start off by thanking everybody for taking time out of their day-to-day, out of their busy schedule to attend the webinar. Today we have a very special speaker. It's my pleasure to introduce him. Dr. Alex Reyzelman is a fellow in the American College of Foot and Ankle Surgeons. He's a senior physician with UCSF Division of Vascular Surgery. He's also an associate professor at the California School of Podiatric Medicine at Samuel Merritt College. He's board certified in foot surgery by the American Board of Podiatric Surgery. He's a co-director of the UCSF Center for Limb Preservation, which specializes in treating lower extremity wounds in patients at high risk of amputation, particularly those with diabetes and peripheral arterial disease. Dr. Reyzelman is extensively involved in research, has published numerous papers in peer-reviewed journals, and is a member of many professional associations such as the American Podiatric Medical Association and the American Diabetes Association. And I personally have had the pleasure of hearing Dr. Reyzelman speak on several occasions and on several topics involving wound healing and limb preservation. It is evident in his message and with his continued research development that he strives to find better, faster, and reliable ways of healing patients suffering with chronic wounds, and ultimately the goal of limb preservation. So I will turn this over to Dr. Alex Reyzelman.
Everybody, good evening to everyone. What I'd like to do is start this presentation and then for all of you to keep the questions, and hope you will ask those questions after the presentation. So what we're going to do is just go over the goals and objectives for the next 15 to 20 minutes. What I'm going to talk about is the treatments of diabetic foot ulcers and why they fail, what barriers to healing of diabetic foot ulcers exist. We will touch upon wound inflammation and its importance to healing. Then we'll talk about autolytic debridement and follow that up with why picking the correct dressing, primary dressing, is important in wound healing. And we'll end with the use of Electra smart dressing ulcers. But before we begin the webinar, I'd like to plant a seed at this point and show you a case of mine that I've had a year ago. A patient that had this wound on the left, this is day 4 to day 11, to a wound that looks like you see on the right. And the question I'd like to pose is this possible without surgical debridement? And I'd like to just ponder that thought for a few minutes, and we'll return to it in a little bit. This algorithm for treatment of diabetic foot ulcers was published by Rob Kirshner from Miami in 2012. And this is somewhat standard. I think majority of us who treat diabetic foot ulcers all realize that the standard therapy for diabetic foot ulcers is offloading. It's paramount. Debridement is very important, and certainly wound bed preparation in order for the wound to heal. Now, typically, most of the clinics that I've ever been associated with usually see patients once a week. It could be more frequent, could be less frequent. But if your treatment regimen is working, you want to see a roughly 50% reduction in size at about 4 weeks. And if everything is going according to plan, if the ulcer is reducing in size by roughly 50%, then continue the regimen and everything should heal. However, if the reduction size has not reached 50% or so at 4 weeks, then we need to consider other factors that are playing a role in why the wound is not healing. And typically these factors are, and when it comes to diabetic foot ulcers, are infection, missed osteomyelitis, ischemia that goes undiagnosed, and certainly inadequate offloading. And those are the main 3. And sometimes we see a weird one such as malignancy or maybe adjunctively poor nutritional status. But for the most part, when we talk about diabetic foot ulcer healing issues, we're talking about offloading, infection, and PAD. I think it's fair to say that many of us who treat diabetic foot ulcers do a pretty good job at offloading. And we think that we're pretty good at diagnosing peripheral arterial disease, picking that up and referring these patients to appropriate interventions, whether it's vascular surgeon or some form of interventionalist. We also do a pretty good job at detecting infection and treating infections. But if we mitigate all of these three factors and the wound still goes unhealed, then we really have to focus at these three boxes that I left for you here. One of them is pro-inflammatory cytokines, increased levels of pro-inflammatory cytokines, high levels of MMPs, which are matrix metalloproteinases, and low mitogenic or poorly functional cells that we call senescent cells. And all three of these should fit into the category of inflammation. And we'll talk about this in the next few minutes. Now, it's easy to talk about pro-inflammatory cytokines, and it sounds fancy. We talk about MMPs. The real question to the clinicians is, how do we recognize these factors? How do we know that these wounds are not healing, and what does it look like in real life? And here is a slide that really shows us some of these objective findings that we see on wounds that tell us that the wound is stuck and it's not moving forward. Lack of pink-red granulation tissue, no decrease in size, pale white, yellow, dark wound base, increase in exudate. And increase in exudate we're going to spend more time talking about because this is paramount when it comes to inflammatory process. Certainly foul odor or malodorous wound and periulcer erythema, such as what you see here around this wound. Even though this wound looks like it has good granulation tissue, the periulcer erythema certainly plays a role, and it tells us that something is going on and prevents this wound from continuing to epithelialize. This slide here, and I'm not going to bore you with the biochemistry of wound healing. I think many of us, if not all of us, have seen this once or twice before. But I will tell you and point out something that's really important. Inflammatory phase is typically 4 to 6 days, can go a little bit longer, and then it goes into proliferative phase. Now, characterization of proliferative phase is really tissue. That's the only way to really think of how the wound is progressing. If it forms granulation tissue, we know it's moving forward. What's interesting here is this overlap between inflammatory phase and a proliferative phase, which many of us don't necessarily realize, myself included. For many years, I didn't really appreciate this as much as I appreciate now. And what this means is the wound that goes through inflammatory phase does not necessarily stop and move on to granulation tissue. It actually has this major overlap. And it also tells us that a wound that's granulating can certainly jump back into the inflammatory phase. And this is the crux of the problem for non-healing wounds. What I'd like to show you on this slide is just point you into these two pictures. This is the same patient that has at different time points. The one on the bottom here has robust red granulation tissue with epithelializing borders, very little to no periulcer erythema. There's minimal exudate. And the same patient here has slough, has light granulation tissue. It's not very robust. It's not very red. It has these rolled borders. It has periulcer erythema. And mostly this wound just looks angry. And this is exactly what inflammatory phase looks like. And if you have a wound that looks like this wound cannot progress in an orchestrated fashion. And what's interesting about this slide here is this wound here actually was doing well, and then 2 weeks later, it became something like this. So I want you to just think about inflammation. If you take away nothing from this webinar, at least take away the idea that inflammatory phase is something that we really need to focus on, and we need to control and address it. One of the major inhibitory factors that promote inflammation is wound exudate. Now, we all know that exudate is normal. Almost every wound has exudate, and in small amounts, an acute wound, acute exudate stimulates cell proliferation. However, in chronic wounds, when there is more exudate, it contributes to delayed healing because we have increased levels of MMPs, and these matrix metalloproteinases actually degrade, break down not only extracellular matrix, but they also break down the growth factors, selectively inhibit proliferating cells. So exudate in chronic wounds and heavy exudate or moderate to heavy exudate is actually very much of a problem in these wounds. And the longer a wound stays open, the more difficult it is to return it to an acute state. Here you see a couple of ulcers that are characterized by significant amount of exudate. Certainly the wound base does not look healthy and clean, but without controlling this exudate, this wound has no chance of turning into a granular, healthy wound. Another major inhibitory factor and promotes inflammation is bioburden. Now, I think many of us have heard of bioburden, and the definition of bioburden is the quantitative estimation number of viable organisms living in a wound, implant, and other surfaces. It represents contaminating organisms that can colonize and lead to infection. But what's interesting here is that bioburden does not necessarily mean the wound is infected. Bioburden means that the wound is increasing the number of microorganisms. And this increase in microorganisms further leads to pro-inflammatory cytokines, increase in level of MMPs, increase in necrotic tissue, and all of this leads to inflammation. So where do we go from here? How do we manage this on the clinical level? Because that's really the bottom line is, what are we going to do tomorrow when we see these patients in the office or clinic? And I think the keys are obviously to debride the wound, reduce the bioburden, and manage the exudate. We talk about different types of debridement, and when we discuss debridement, I think many of us really believe that debridement is surgical, and usually everybody would say that's the only way to do it, and that's the most effective way to promote healing. We do have some studies in the literature, not that many, but there are a couple of good ones. One was published in 2009 by Matthew Cardinal, and what they did was they looked at retrospective analysis of 2 controlled prospective randomized trials. They looked at 310 diabetic foot ulcers, patients that had serial debridement and patients that had no serial debridement. What they found was patients with serial debridement had higher rate of healing, shorter time to heal their wounds. Another landmark study that most people refer to when they promote surgical debridement is the David Steed article. And Steed looked at a randomized prospective trial of diabetic foot ulcers, about 118 diabetic foot ulcers over 10 centers, and he retrospectively reviewed the data. All of these patients had to have aggressive sharp debridement. However, not all centers had frequent debridement. So he compared various centers, and what he found was that centers with more frequent debridement had a higher rate of healing. Well, that's great, but we all know, if we're honest with ourselves, that despite our weekly debridement, and most of us do this on a weekly basis, despite our surgical weekly debridement, we still have plenty of patients that don't heal for one reason or another. And these are examples here. These are all my patients that despite debridement just don't do well. Where does that leave us? Why is that the case? Well, we have data to support that despite aggressive treatment of diabetic foot ulcers, they still don't do well. This is a study that was performed by Margolis and published in 1999, looking at multiple prospective diabetic foot ulcer trials. And what David Margolis did was he looked at all of these placebo arms of all of these trials in a meta-analysis. And he found that despite surgical debridement, despite offloading, and despite creating a moist environment, only 25% of patients healed at 12 weeks. And if you carried it out to 20 weeks, only 31 patients healed. So now we have some conflicting data. I just showed you some evidence that supports surgical debridement in terms of healing wounds. And now I'm showing you that despite surgical debridement, we still don't heal majority of our wounds. So where did we go wrong? Well, maybe we need to consider that something needs to be added to the surgical debridement. Maybe we haven't had the appropriate treatment. Maybe we haven't thought of it the right way. And that leads us into autolytic debridement. Now, if you're like me, for many years, I never really understood autolytic debridement. I knew it existed, but it didn't make sense to me. Yes, it's somehow the body's way of cleaning up the wound, but that's all I knew about it. And it wasn't until several years ago that it really clicked. and made me understand that autolytic debridement is very powerful. Definition of autolytic debridement is the process by which the wound bed utilizes phagocytic cells and proteolytic enzymes to remove debris. And this can be accomplished by judicious use of occlusive and semi-occlusive dressings that can promote this natural process, controlling what? Controlling the exudative levels and maintaining the moist wound environment. And the key here is controlling the exudate, as we will look at in a little bit. I showed you this case when we first started, and this was the case that really drove the point across. This is where I really understood the power of autolytic debridement. This is a patient who has had this wound for over a year. She's immunosuppressed, has had multiple surgical debridements, not only in the clinic, but she had to go to the operating room on several different occasions. She's had all types of treatment, and she would not let anybody take a knife to this wound. As you can see here, day 0 to day 4, we accomplished this improvement in granulation tissue in just 4 days with a certain dressing that we're talking about today. And the reason we did that is because of autolytic debridement. So without doing any surgical debridement, we were able to transform this wound here into this granulation tissue, this beautifully healing wound on this side of the slide. Here's another example of a similar patient who has had this wound for many, many months, almost a year. You can see a lot of slough. This is heavily contaminated wound. There's a lot of bioburden here. This wound had absolutely no surgical debridement, and you can see what happens to it within 21 days. The wound is now 100% granular, and only at this point, once it reaches this point, can it start to heal and epithelialize. And again, this was accomplished by autolytic debridement alone. So if we summarize so far where we are, we can really say that balancing the inflammation is the key, and it's really the holy grail of successful wound healing. If inflammation is unchecked and persistent, it can lead to a non-healing wound. And the goal for us as wound care professionals is to reduce the inflammation and allow the wound to progress through the healing cascade in an orchestrated fashion. So maybe there should be a paradigm shift somewhat of understanding the debridement and not thinking that the debridement is only once a week or once every 2 weeks. Debridement is a continuous process, and it's the combination of surgical and autolytic debridement, codependent on each other, that is the way to move forward. Because if we see Monday to Monday, something happens for a week between those times, and we're not controlling that. And if we can control that time between our visits, then I think we should be able to heal more wounds. So what are the wound care challenges that we're facing when we're looking at these wounds? Well, we know that wound is non-homogeneous, and it's a dynamic entity. Wound is changing unpredictably during dressing wear. Again, from Monday to Monday or Tuesday to Tuesday, the wound has a dressing on there, but we have no idea, because we don't see the patient, what the wound looks like. Various wound tissue types and components with various levels of drainage coexist within the wound. And what that means is that specifically with diabetic foot ulcers, we frequently see that part of the wound has slough, fibrous tissue, part of the wound may have granulation tissue, part of the wound may be moderately to heavily exudative, while the other part may have very low exudative ability. So how do we accomplish all of these different things? How do we target this wound when it has all these different things going on? We know that each wound tissue type and component has to be addressed with a specific set of dressing functions. But what's important, it needs to be all done at the same time, but only as needed. Localized over corresponding areas of the specific tissue types and components, and dynamically and reversibly following evolving wound. So the wound is dynamic, and the dressing needs to be dynamic as well. And that's really the key to allow autolytic debridement to occur. So this brings us to, in Electra, the smart dressing. Now, why is it called the smart dressing? A smart dressing because it's the first and only self-regulating superabsorbent fiber dressing with adaptive absorbency and built-in adaptive hydration function. It's suitable for wounds with any drainage level from low to high. And it addresses each distinct wound area individually, and it adjusts its properties over each area in response to evolving wound and environment. So how does it do this? Well, the smart dressing, the Electra, is able to detect high humidity and high moisture content. And based on that, it becomes more permeable to fluid and it absorbs. At the same time, in dry areas and desiccated areas, it senses low humidity and creates optimal moist environment and is able to hydrate the wound. Electra has a unique feature. Due to its porous structure, it absorbs and takes away not only the solid but also of autolytic debridement, and it helps to promote intensive natural wound cleansing. So if we summarize Electra, we can summarize it in a way to say that it's continuous cleansing of the wound bed and evacuation of liquefied slough and debris. It's able to bring the wound out of inflammation stage. And I've mentioned inflammation before, and I think this is really, really important. Our goal is to progress the wound from inflammatory stage to the proliferative stage, but not only to progress it in that direction, but also to prevent it from returning to inflammation stage and allow it to further granulate the wound and further reepithelialize the wound margins and progress to healing. The second part that Electra does, it has on-demand hydration of dry and low exudating wounds. And it supports this optimal moist microenvironment for cell multiplication and proliferation. It's also able to maximally absorb all this fluid. Now, when you think about Exudate, and we talked about chronic, moderate to heavy exudative properties, we talked about having MMPs. All of those things are important because if we can't absorb it and lock it in place, then that exudate, those enzymes that are sitting on the wound, they're able to further debride and further break down the granulation tissue process that has been occurring. I want to show you a couple of case studies. And there's nothing special about this particular patient except this is a diabetic patient with a dorsal foot wound. We did not perform any surgical debridement at this stage, and you can see how it progresses from 1 month to the next. What I want you to really look at is the fact that there is no peri-ulcer inflammation. Applying Electra is able to control not only the wound base, but also the wound margins as well. And from 1 month to the next, from 1 week to the next, we see more epithelialization, and eventually this wound goes on to completely heal. This is the more classic diabetic foot ulcer. This is the plantar foot ulcer, and I think this is what we typically think of when we talk about diabetic foot ulcers. What's interesting about this particular patient is that he has 2 ulcers separated by an island of skin. And the question is, well, how do we dress this? Do we apply one dressing? And if we do, are we concerned about this area being macerated and breaking open? And what's special about Electra is that property that we talked about earlier, that it can detect various zones of drainage or exudate, and it can donate moisture to a dry area, and it can absorb moisture from a draining area. So even if we put one piece of Electra on the entire wound that has multiple ulcers, it is not going to create more maceration. On the contrary, it's going to be able to absorb everything and provide the appropriate moist environment for these ulcers to heal. So at this point, what I'd like to do is turn it over to Vicki to continue the webinar, and then we can open up to questions.
So thank you, Alex, for that great presentation. And I just want to go over some quick things about Electra and some of the key points that Alex talked about as far as the inflammation, the chronic inflammatory state. So with Electra, some of the key things to do is the sizing of the dressing. So the sizing of the dressing needs to also include the peri-wound issue. So anything that's happening around the peri-wound area needs to be included into the sizing of the dressing. It needs to go out 1 inch out onto the healthy skin. So still to this day, that's one of our biggest issues that I continue to see. So my motto on this is go big or go home. If you remember nothing today, go big or go home on the size of the dressing for the first 3 to 4 dressings. Make sure that you're making good contact with the wound bed or the wound filler. So if you can use this on deeper wounds with cavities or undermining or tunneling. Just be sure you're using a material that doesn't shrink, so no alginates, no Aquacel AG. Make sure that you remove the dressing before or more frequently on heavy bioburden wounds. You want to remove it before 7 days or before drainage reaches the border's edge. Educate your patient. Let them know that if they're hurting, burning, stinging, smelling, more than likely the drainage has reached one of the border's edges and it's irritating them. So one of the things that causes a lot of irritations with the use of Electra is if you're continuing to use any kind of co-products underneath Electra. So if you're using any zinc paste, petroleum-based products, cream-based products, those particular products underneath Electra can also cause the patient some irritation. So you want to stick to something that's water-based or not thick or viscous. So no santal, no petroleum-based products. Those particular products are going to interact with Electra. So Electra is FDA approved. It reimburses. Our HIPAA codes are A code 6196, 6197. So it's a good amount of dressings. You get 30 dressings per month per wound. You can get some of this information for how to get the distributor list in our DMN list on Electra.com. And there's other opportunities if you'd like to know a little bit more of the application process within Electra. Please, we encourage you to sign up for a private live webinar and get some training and education on the use of Electra prior to using it. So our numbers are listed below. That's our clinical line or my phone number directly if you'd like to sign up for some further information. There's also Facebook. Please go to our Facebook site or contact osnovative.com or Electra.com. We want to open this up for questions right now. So any questions for Dr. Reyzelman, please, or if you'd also like to email them in. So we do have a question right now. One of the first questions we have is basically where is Electra available? So Electra, if you go to our website, is available through many distributors. So one of the questions we have already is about manual debridement will produce bleeding. Electra is good over that. So Electra does intensify the body's natural autolytic process. And so there will be times when that you're using Electra on frequent dressing changes on heavy bioburden wounds that your wound bed will actually become very vascular. Expect that. That's a normal process of healing, and it'll transition out.
In terms of debridement and creating some bleeding and then using Electra, we do it all the time. Of course, the bleeding has to be controlled. Hemostasis has to be achieved, so there's no active bleeding. But if there's some oozing, it's not a big deal. We usually put Electra right over it. And then the frequency of the dressing change is important. If we think there's a concern, we may change it more frequently. And then if the wound is looking good and it's not bleeding and there's not too much Exudate, then we may leave it for 3, 4, 5, or 7 days. And that's one of the advantages of Electra is that we have that luxury of either changing it daily or leaving it for several days or up to a week.
One of the other questions is if you can use flagell crushed under Electra. You could. Powder-based products could be used, but also remember the Electra draws in and locks in the Exudate. So on frequent use, so if you have a heavy bioburden wound with lots of drainage, what you want to do is change it more frequently at the beginning of use. If you would like to use the flagell, you could underneath it. Powder flagell. but you still will need to increase the frequency of change early on. Dr. Reyzelman, would you like to answer any of these questions?
Sure. You know, in my experience using Electra, we try not to put anything between the wound and the Electra if we can. I'm sure powder is not going to be a big deal and it's not going to do too much, but the idea of Electra is to be able to have direct contact with the wound and allow autolytic debridement to occur. If there's a need for antibiotics, we typically use oral antibiotics if we need to. And of course debride surgically if we need to, but we like to allow Electra to perform its function and promote autolytic debridement by itself, usually.
Okay, we have several other questions. So I mostly treat patients with pressure ulcers. Can I use the same approach and treat them with Electra?
Pressure ulcers, venous leg ulcers, any type of ulcer, surgical wound, it really doesn't matter. A wound is a wound. And we're just following the same principles. If it's necrotic, it needs to be debrided, and then autolytic debridement needs to be promoted, and Electra can be used for that. I think we found in our setting is that we don't have the luxury of having many options for dressing choices. So we're always looking for this universal dressing, one that can accomplish multiple things. And that's where we found the advantage of Electra. We don't stock too many dressings. We tend to keep Electra as one of our only absorptive dressings. And also, we rarely use hydrogel. We believe that Electra promotes and donates plenty of hydration to the wound, where we don't have to use hydrogel independently and stock different dressings. So I think that's been really helpful to us.
Okay, I've got another question. If the Exudate is so great that the dressing is not lasting 24 hours, can you change it twice a day?
I'll start first, and you can certainly give your experience too. Of course, you can change it as often as you need to, and really the Exudate drives everything. You want to make sure that the Electra is not leaking and it's not breaking up on you, because if the drainage is too much for Electra to carry, then it defeats the whole purpose. So you want to create the best possible moisture, appropriate moisture balance for the wound base. And if it's highly exudative, we have to control it at all costs. And if it's BID dressings, then that's what it takes. But usually we find that if it's draining a lot, we'll change it more frequently, and then we'll decrease the frequency as the drainage is controlled.
Yes, the only thing I'm going to add to that is the importance of the sizing. So when you have a high draining wound, be sure that you're sizing the wound, sizing the dressing appropriately. So you definitely want to remove Electra before it's pouring out the borders edges. One more question here. Is Electra available or is covered by prescription, or is it covered by any medical plans?
Do you have the answer to that question, Vicki?
Yes, Electra is definitely available by prescription. If you'll go to our website, you'll see a list of our DME providers and our HIPAA codes. So Electra is available 30 pieces per wound per month. So you could do it daily. Of course, the goal, or hopefully the goal, is to extend the wear of the dressing as you get ahead of the conditions of either the exudate, the slough. And I think we have another question. Is there a need for biofilm detection if Electra is able to remove the biofilm? So, Alex, I can answer that, or you can answer that.
Go ahead and I'll chime in.
Is there, so biofilm, there is a lot of biofilm detection, DNA detections that are available now. And if you're using DNA sequencing for your detection, you could still use it. Is Electra going to help with the removal of the biofilm? Yes, it will decrease it in time. You'll have to change the frequency, but there may be a need that you may want to do a DNA sequencing in order to treat empirically or whatever type of treatment you're going to do. But yes, Electra works really well with highly infected wounds, and in my opinion, it should be used on highly infected wounds because it's going to help deal with that bioburden with every dressing change. Alex, do you want to add to that?
Right. I think that we really underestimate the power of autolytic debridement. And we tend to focus on surgical, sometimes enzymatic debridement, but really autolytic debridement occurs 24/7. And if you just think about that for a second, 24/7, something is going on. And if we can promote an appropriate environment for that process to continue, then it can break through the bioburden, it can break through the biofilm, it can control everything and clean up that wound faster than anything else. You have to understand that the surgical debridement, it's a one-time thing. We take care of it, and then 1 week later when we see the patient has had 6 days, and that wound has had 6 days to deteriorate. And sometimes it doesn't deteriorate, but many times it does. So we need to find a way to control that 6-day period or whatever that period between our visits. I think that's really something that I poorly understood in the past, and I understand that much better.
Okay, so we have one more question. Can you explain why alginates are not good to use within Electra? Alex, I have this one unless you'd like it.
No, it's all yours.
Okay, all right. So alginates, they're really not, in my opinion, just really good wicking fibers. It's not going to work. So if you're using an alginate for a filling material, the second it gets moistened with wound drainage, it's going to shrink and you're going to lose contact with Electra. So the key with Electra is whatever filler material you're using for tunneling, undermining, or any space cavity that you're filling, that material, your filler material, needs to stay in contact with the undersurface of Electra. So we have some new techniques for that. And that's why I encourage you guys after we get done today to sign up for an application, because I can show you exactly how to use the appropriate fillers. You want a filler material that does not shrink, that stays in contact with Electra at all times. It'll draw off that filling material. The alginates and the aquacelluloses, any cellulose type products, are actually going to block the vertical draw of Electra, and you will end up with a very macerated wound bed. And I've tried every one of them. I've tested every product, and 6 years ago I have pictures to prove that it doesn't work.
And I have something to add to this. I think one thing that we tend to miss, and I'm speaking more for podiatrists in the group, is the dressings usually accomplish one thing. So if you're thinking of calcium alginate or some other absorptive dressing, it absorbs, but it does nothing more than that. The difference between Electra is that it's able to absorb and hydrate at the same time. So we all know that the wound has multiple zones within the wound. They're not all uniform. So when you put Electra on it, you can be sure that it can detect different parts of the wound in a different way. And that's why it's called a smart dressing, because it's able to do that, versus calcium alginate, it's only able to absorb. So then once you've done that, you have to change the dressing to go somewhere else. Maybe it's now drier and you need to put something more like a hydrocolloid or a hydrogel or whatever. With Electra, you don't need to do that. That's the biggest advantage that we have seen.
Okay, well, I'm not seeing any more questions at this time. So if there's any further questions, you can email them. We'll provide an email. We can continue to answer questions throughout the week on this. And please, I encourage you to sign up for a webinar application if you have any further questions. So I just want to thank you today for presenting Dr. Reyzelman information to everybody, and thank everybody for attending today.
Thank you.